Hello, I'm Professor Peraza, and today's lecture video covers carbohydrates. These are the specific learning objectives for this module. This module also meets the following course learning objectives. For this lecture, these two free textbooks are your primary reference materials. More information, including page numbers for readings, can be found in the Canvas course space for this module. Before we get into lecture, I want you to think of the following energy-yielding macronutrients: carbohydrates, lipids, or proteins. Which do you think is the most important? Kind of a trick question. There's not one most important energy-yielding macronutrient because carbohydrates, proteins, and fats each have unique and essential roles in the body. The ideal balance depends on an individual's health needs, activity level, goals, and overall dietary pattern. We will cover this more in this module. This slide should look familiar from Module 1. Let's do a quick overview on carbohydrates before getting more into other details. Carbohydrates are molecules composed of carbon, hydrogen, and oxygen. Carbohydrates can be classified as simple or complex. Carbohydrate sources include grains, dairy products, fruits, legumes, and starchy vegetables like potatoes. Non-starchy vegetables like carrots also contain carbohydrates, but in smaller quantities. Carbohydrates are our brain's primary fuel sources. Carbohydrates are needed as an energy source, along with functioning of the nervous system, heart, and kidneys. We will cover more specific functions of carbs later. At the bottom of the slide, the physiological fuel value for digestible carbs is listed, 4 kcals per gram. So 1 gram of digestible carbohydrates yields 4 kilocalories of energy for our cells. We have talked a little about carbohydrate functions, but let's explore this more. There are some key functions of carbohydrates in the human body. The primary role of carbohydrates is as fuel for production of energy in body cells. Many cells prefer glucose as a source of energy versus other compounds like fatty acids. Some cells, such as red blood cells, are only able to produce cellular energy from glucose. The brain is highly sensitive to low blood glucose levels. There is an alternative fuel, ketone bodies, that the brain can use under conditions of starvation, but it uses glucose to function under normal conditions. If the body has enough energy to support its functions, the excess glucose is stored as glycogen, the majority of which is stored in the muscles and liver, allowing for rapid use of glucose when it is needed to make cellular energy. Prolonged muscle use, such as exercise for longer than a few hours, can deplete the glycogen energy reserve, leading to fatigue and a decrease in exercise performance. Although most absorbed glucose is used to make energy, glucose can be used to build ribose and deoxyribose, two components of the important macromolecules, RNA, DNA, ATP, and NADPH. NADPH protects against oxidative stress, and it is used in many chemical reactions in the body. If there's not enough glucose to meet the body's needs, glucose is synthesized from amino acids. Because there's no storage molecule of amino acids, this process requires the destruction of proteins, primarily from muscle tissue. The presence of adequate glucose spares the breakdown of proteins from being used to make glucose needed by the body. Let's talk about simple sugars, which includes monosaccharides and disaccharides. Monosaccharides, or single sugars, include glucose, which is the sugar circulating in your bloodstream, fructose, which is found in fruits, vegetables, honey, and high fructose corn syrup, and galactose, which is primarily found in milk and dairy products. Glucose is one of the most important nutrients for fueling the body. It's especially important for the brain and nervous system, which aren't very good at using other fuel sources. Glucose is the preferred fuel source for many organisms and most animal cells. The brain depends on glucose as its energy source, except during starvation conditions. Fructose is the sweetest carbohydrate. Plants make a lot of fructose as a way of attracting insects and animals, which help plants to reproduce. Galactose is one component of the milk sugar lactose, but is not found in many other foods. It is almost always linked to glucose to form a disaccharide, which we are covering next. The body easily converts fructose and galactose to glucose. We also have sugar alcohols, which are derivatives of monosaccharides. Examples of sugar alcohols are sorbitol, xylitol, and glycerol. Xylitol is similar in sweetness as table sugar. Sugar alcohols are used in food manufacturing to sweeten foods as they are incompletely digested and absorbed and therefore less caloric. The bacteria in your mouth do not digest them and produce tooth-damaging acids, so sugar alcohols do not cause tooth decay. Disaccharides, or double sugars, include lactose, maltose, and sucrose. Lactose is made up of glucose and galactose. Lactose is prevalent in dairy products like milk, yogurt, and cheese. Sucrose, which is made by crystallizing sugarcane or beet juice, is made up of glucose and fructose. It is in high concentrations in sugar beets and sugarcane used to make table sugar. Sucrose is naturally occurring in fruits and vegetables. Most fruits and vegetables contain a mixture of glucose, fructose, and sucrose. Maltose is made up of glucose and glucose. It doesn't occur naturally in any appreciable amounts in foods, with one exception: sprouted grains. When grains sprout, they break down starch and create maltose. Maltose also plays a role in the production of beer and liquor because this process involves the fermentation of grains or other carbohydrate sources. Maltose is formed during the breakdown of these carbohydrates, but there is very little remaining once the fermentation process is complete. Let's review the complex carbohydrates, which include oligosaccharides and polysaccharides. The oligosaccharides include raffinose and stachyose, and you can find these in onions, cabbage, whole wheat products, and legumes. These oligosaccharides pass largely undigested into the large intestine, where bacteria metabolize them and produce intestinal gas and other byproducts. The polysaccharides include starch, which is digestible. Starch is made up of long chains of glucose. If these chains are straight, they're called amylose. If they're branched, they're called amylopectin. Sources include tubers, potatoes, rice, beans, and pasta. Refined starch, like cornstarch, is often used as an ingredient in processed foods as a thickener. Glycogen is another example of a polysaccharide, and it is the storage form of carbohydrates in humans and animals. It's made up of highly branched chains of glucose, and it's stored in the liver and skeletal muscle. The branch structure of glycogen makes it easier to break down quickly to release glucose to serve as a fuel when needed on short notice. Liver glycogen is broken down to glucose, which is released into the bloodstream and can be used by cells around the body. Muscle glycogen provides energy only for muscle to fuel activity. Both liver and muscle glycogen serve as relatively short-term forms of energy storage. Together, they can only provide enough glucose to last for about 24 hours in a person fasting or eating a very low carbohydrate diet. We are going to review fiber on the next slide. Fiber is the last example of a polysaccharide we are going to cover. Dietary fibers are polysaccharides that are highly branched and cross-linked. All dietary fiber comes from plant-based foods, including fruits, vegetables, whole grains, legumes, nuts, and seeds. Some dietary fibers are pectins, gums, cellulose, hemicellulose, and lignin. One of the most common types of fiber is cellulose, the main component in plant cell walls. Fiber is largely indigestible and will pass into the large intestine, where bacteria metabolize and form short-chain fatty acids and gas. Gut bacteria ferment fiber to produce short-chain fatty acids, which have anti-inflammatory effects that further support gut and metabolic health. Total fiber includes dietary fiber that occurs naturally in plants, and functional fiber, which includes isolated or synthetic fibers that may be added to food or be used as a supplement. Functional fibers can be isolated or extracted from a natural plant source or manufactured. Dietary fiber is categorized as water-soluble or insoluble. Soluble fibers are more easily accessible to bacterial enzymes in the large intestine, so they can be broken down to a greater extent than insoluble fibers. Soluble fibers dissolve easily in water and gel together. Some examples of soluble fibers are inulin, pectin, and guar gum, and they are found in peas, beans, oats, barley, and rye. Soluble fibers have been shown to reduce blood cholesterol levels by binding to cholesterol and bile acids, which reduces circulating cholesterol levels. Soluble fiber also slows gastric emptying, delays glucose absorption, and blunts post-meal blood sugar spikes. Insoluble fibers do not dissolve in water and can be found in seeds, whole grains, celery, legumes, and the skin of fruits and vegetables. Lignin, cellulose, and hemicellulose are common types of insoluble fibers. Insoluble fiber has been shown to reduce the risk of constipation by creating a softer, bulkier stool and also aid in decreasing transit time. Many foods have a combination of soluble and insoluble fibers. An apple, for example, has insoluble fiber, cellulose, in the outer skin and soluble fiber in the inner cells, pectin, gums, mucilages. There are many benefits of consuming dietary fiber outside of what I already mentioned. Research shows that dietary fiber is linked to lower rates of cardiovascular disease, type 2 diabetes, and colorectal cancer. Certain soluble fibers like pectin may have antioxidant properties that help prevent cancers, including breast cancer. Fiber also lowers LDL cholesterol and blood pressure. Both soluble and insoluble fibers enhance satiety, aid in weight management, and support cardiovascular and metabolic health. The recommendation for fiber is set at 14 grams per 1,000 calories for those over the age of 1. Most Americans are not getting enough fiber in their diet. This is largely due to low intakes of fruits and vegetables and high consumption of ultra-processed foods, which are typically low in fiber and high in added sugars and fats. Although fiber is beneficial, too much can be a concern, especially if also consuming a low fluid diet, as this can lead to constipation. Generally, this is not a concern unless fiber intake is over 50 to 60 grams per day. Increasing fiber intake too quickly can also cause bloating, gas, cramping, and general gastrointestinal discomfort. These effects are more pronounced with certain types of fiber, highly fermentable soluble fibers, inulin, resistant starch, and some oligosaccharides. Gradual introduction over a few weeks allows the gut microbiota and the digestive tract to adapt. Adequate hydration is also essential as water helps fiber move through the intestines and prevents constipation. It is best to gradually increase fiber intake by about 2 to 3 grams every few days, monitor tolerance, and adjust as needed to minimize discomfort while modifying eating habits to meet optimal fiber intake. We've talked about fiber, and I want to highlight whole grains as they are also a source of dietary fiber. Consuming more complex carbohydrates is beneficial to health. Replacing refined grains with whole grains decreases the risk for obesity, type 2 diabetes, and cardiovascular disease. Whole grains are rich dietary sources of fiber, vitamins, minerals, healthy fats, and other beneficial plant chemicals, phytochemicals. Before harvesting, all grains are whole, meaning they contain the entire seed or kernel of the plant. There are 3 edible parts: bran, germ, and endosperm. There is also an inedible husk that protects the seed. Examples of whole grains include whole wheat, corn, including popcorn, brown rice, oats, and rye. When a food is refined, this means the outer bran layer is removed along with the germ. The bran contains antioxidants, B vitamins, and fiber. The germ, which is the embryo of the seed, contains B vitamins, protein, zinc, magnesium, and healthy fats. What remains is the endosperm, which is mostly starch and a small amount of protein, vitamins, and minerals. Grain products can be enriched, which means some of the missing nutrients are added back in. This includes thiamine, riboflavin, niacin, iron, and folic acid. Labeling terms can get confusing, so let's talk about whole wheat versus whole grain. Whole wheat is simply one kind of whole grain. One way to tell if a product is 100% whole grain is to look for the 100% stamp from the Whole Grains Council. This means all grain ingredients are whole grain. You can also look at the ingredient list on the Nutrition Facts panel. Look for 100% whole wheat or whole grain versus enriched wheat flour or white flour. The 2020 dietary guidelines recommend consuming at least half of your grains as whole grains. The 2025 dietary guidelines recommend prioritizing fiber-rich whole grains, aiming for 2 to 4 servings per day, adjusting as needed based on individual caloric requirements. A serving would be half a cup cooked oats, brown rice, barley, quinoa, or buckwheat, or a slice of whole grain bread. This doesn't mean you can't ever eat products like white rice, which is a staple in many cultures. The important thing is to look at your intake for the day. Let's review carbohydrate recommendations. 45 to 65% of calories from carbohydrates, children 1 to 18 years old, and adults for the AMDR. The quality of those carbohydrates matters, focusing on whole, minimally processed foods like fruits, vegetables, and whole grains. The AI for fiber is set at 14 grams per 1,000 calories. The recommended adequate daily intake is 25 grams for women and 38 grams for men. The RDA for digestible carbs was set in the DRI by the National Academies. Digestible carbohydrates are a primary energy source, as the central nervous system and red blood cells derive almost all of their energy from glucose. For children older than 1 and adults of all age groups and sexes, the recommended dietary allowance is set as 130 grams per day. The RDA changes to 175 grams per day during pregnancy and 210 grams per day during breastfeeding. I want to review added sugars more in detail. Added sugars include those added during food manufacturing and do not include naturally occurring sugars. Maple syrup and honey are considered added sugars as they are single ingredient and added to food. Consuming too much added sugar can contribute to health problems such as weight gain and obesity, type 2 diabetes, and heart disease. According to the DGAs, the leading sources of added sugars in the U.S. diet are sugar-sweetened beverages, desserts, and sweet snacks. Added sugar recommendations vary based on the 2020 DGAs, 2025 DGAs, and even recommendations from the American Heart Association. The 2020 DGAs say added sugars should be less than 10% of calories per day starting at age 2. Avoid foods and beverages with added sugars for those younger than age 2. The 2025 DGAs say for birth to 4 years, avoid added sugars during infancy and early childhood. For ages 5 to 10 years, no amount of added sugars is recommended. It is also noted that one meal should not contain over 10 grams of added sugar. The daily servings by calorie level chart also note added sugar limits for products with healthy claims. This includes a limit of 5 grams for grains, 2.5 grams for dairy, 1 gram for fruits, vegetables, beans, nuts, seeds, and all other protein sources. The American Heart Association says to limit added sugars to no more than 6% of calories each day. This would be for most women, 6 teaspoons or about 25 grams of sugar, and 9 teaspoons or about 36 grams for men. We covered digestion previously, but let's take a closer look at carbohydrate digestion and absorption. The mechanical and chemical digestion of carbohydrates begins in the mouth. Chewing, also known as mastication, crumbles foods into smaller and smaller pieces. The salivary glands in the oral cavity secrete saliva that contains the enzyme salivary amylase. This enzyme breaks the bonds between starches into smaller chains of glucose. Only a small amount of starches are broken down in the mouth, though. In the stomach, salivary amylase is inactivated and digestion of carbohydrates mostly stops until the small intestine. This is due to the acidity of the stomach environment. Mechanical breakdown still occurs with peristaltic contractions of the stomach, mixing the carbohydrates into chyme. The small intestine is primarily where digestion of carbohydrates takes place. The pancreas releases juices with pancreatic amylase and dextrinase work to break down remaining starches and dextrins into shorter and shorter carbohydrate chains. Enzymes are secreted by the intestinal cells that line the villi. These enzymes include the sucrase, maltase, and lactase. Sucrase breaks sucrose into glucose and fructose molecules. Maltase breaks the bond between the two glucose units of maltose. And lactase breaks the bond between galactose and glucose in lactose. Once carbohydrates are broken into monosaccharides, they are absorbed into the intestinal cells and into the bloodstream. The bloodstream carries them to the rest of the body. The first organ to receive glucose, fructose, and galactose is the liver. The liver converts galactose and fructose to glucose, breaks fructose into smaller carbon-containing units, and either stores glucose as glycogen or exports it back to the blood. How much the liver exports to the blood is under hormonal control. Most carbohydrates are efficiently digested and absorbed into the body in the small intestine. Any indigestible carbohydrates will pass into the large intestine where they are fermented by bacteria into short-chain fatty acids and some gases. Short-chain fatty acids can be used by bacteria, eliminated in the feces, or absorbed into the large intestine cells, with a small amount being transported to the liver. The liver can also metabolize the short-chain fatty acids into cellular energy. The cells lining the large intestine can use short-chain fatty acids to support some of their functions. Excessive carbohydrate intake not utilized for glycogen or energy can be converted to body fat. In summary, the primary goal of carbohydrate digestion is to break polysaccharides and disaccharides into monosaccharides, which can be absorbed into the bloodstream. Monosaccharides are small enough to be absorbed as they are. Disaccharides are broken down or enzymatically digested in the digestive tract to monosaccharides, glucose, galactose, and fructose. Starch in food is broken down or enzymatically digested in the digestive tract to glucose. Fiber in food is not enzymatically digested because humans don't have the enzymes to do this. However, some dietary fiber is fermented in the large intestine by gut microbes. Let's talk about glucose regulation in the body. After a meal with carbohydrates, blood glucose levels will rise. Your pancreas will release insulin, which helps to transport glucose into cells to use for energy and also store glucose as glycogen. Insulin is a hormone made by the beta cells of the pancreas. Insulin allows our cells to take glucose in or remove it from the bloodstream and use the glucose to make energy. Muscle tissue and liver store glucose in the form of glycogen when insulin is present. As glucose is transported into the cells around the body, blood glucose levels decrease. As a result, blood glucose levels return to normal, which is typically between 70 and 100 milligrams per deciliter. If we need glucose right away for energy, we can metabolize glucose through cellular respiration. If we don't need this energy right away, it is stored as glycogen or converted to fat. When glucose levels are low, such as when you have not eaten for a period of time, the pancreas releases the hormone glucagon. Glucagon is made by the alpha cells of the pancreas. Glucagon signals to the liver to break down glycogen to release stored glucose into the bloodstream. Additionally, the process of gluconeogenesis is triggered, which is the creation of glucose from amino acids when carbohydrates are limited. Glucose levels in the blood are tightly controlled, as having either too much or too little glucose in the blood has health consequences. Your body's ability to maintain equilibrium or a steady state in your blood glucose concentration is called homeostasis. It's a critical part of normal physiology because if your blood glucose gets too low, as with hypoglycemia, cellular function starts to fail, especially in the brain. Hypoglycemia can lead to feelings of confusion, shakiness, and irritability. Over time, seizures and coma can occur if it persists. If blood glucose gets too high with hyperglycemia, it can cause damage to cells. We are going to cover metabolism later in this course, and we'll discuss starvation and energy sources then. However, I do want to briefly cover what happens when carbohydrate intake and supply is limited for an extended period of time. This can happen during fasting periods, starvation, or with a very low carbohydrate diet. Glycogen is typically depleted in about 24 hours. Your brain still needs glucose, so proteins and fats then come into play. You'll continue to use some amino acids to make glucose through gluconeogenesis and others as a source of energy through acetyl-CoA. However, if a person is starving, they also won't have extra dietary protein. Therefore, they start breaking down body proteins, which will cause muscle wasting. You can break down fat as a source of energy, but you can't use the fatty acids for glucose. Fatty acids can be broken down to acetyl-CoA in the liver, but acetyl-CoA can't be converted to pyruvate and go through gluconeogenesis. It can go through the Krebs cycle to produce ATP or energy, but if carbohydrate availability is low, the Krebs cycle gets overwhelmed. In this case, acetyl-CoA is converted into compounds called ketone bodies. These can then be exported to other cells in the body, especially brain and muscle cells. Ketone production is important because ketones can be used by the body's tissue as an energy source during starvation or low carbohydrate diet. Even the brain can adapt to using ketones as a fuel source after about 3 days of starvation or a very low carbohydrate diet. This also helps to preserve the protein in the muscle. Ketones can be excreted in urine, but if ketone production is very high, they begin to accumulate in the blood in a condition called ketosis. Symptoms of ketosis include sweet-smelling breath, dry mouth, and reduced appetite. We will cover more about ketosis and the ketogenic diet when we cover lipids. I do want to note that ketones are acidic, so severe ketosis can cause the blood to become too acidic, a condition called ketoacidosis. This is not typically a concern for diet-induced ketosis. However, it can happen with uncontrolled diabetes. We will cover this momentarily. What I previously described with glucose regulation is in the absence of diabetes. We are going to cover a few conditions, metabolic syndrome and diabetes. Metabolic syndrome is a group of conditions that can increase your risk of health problems like coronary heart disease, diabetes, and stroke. With metabolic syndrome, an individual must have at least 3 risk factors or metabolic abnormalities: a waist circumference of more than 40 inches in men and 35 inches in women, blood pressure values of systolic 130 or higher or diastolic 85 or higher, elevated fasting blood glucose of 100 milligrams per deciliter or greater, serum triglycerides level of 150 milligrams per deciliter or greater, reduced high-density lipoprotein cholesterol less than 40 milligrams per deciliter in men or less than 50 milligrams per deciliter in women. The cause of metabolic syndrome is multifactorial. While genetics play a role, lifestyle factors that contribute to the risk of metabolic syndrome include obesity, lack of physical activity, and unhealthy dietary habits. A buildup of fatty tissue, especially in the abdomen, leads to insulin resistance. With insulin resistance, tissues are less sensitive to this acute rise in insulin, resulting in higher serum glucose levels and hyperinsulinemia. The impairment in insulin secretion and abnormal insulin signaling results in impaired glucose metabolism, cardiotoxicity, and chronic inflammation, the characteristic features of metabolic syndrome. Insulin resistance causes microvascular damage, predisposing patients to endothelial dysfunction, vascular resistance, hypertension, and vessel wall inflammation. Visceral obesity has been identified as the main trigger in the pathogenesis of metabolic syndrome, and high-calorie intake is the primary cause of visceral fat accumulation. Free fatty acids released by the adipose tissue promote insulin resistance and inhibit insulin secretion from the pancreatic beta cells. The high free fatty acids inhibit glucose uptake in skeletal muscle and increase hepatic gluconeogenesis and lipid synthesis by inducing protein kinases. Both insulin resistance and free fatty acids play a major role in the pathogenesis of hypertension, prothrombic state, and chronic inflammation. The inflammatory cytokines further increase insulin resistance in skeletal muscle, liver, and adipose tissue by inhibiting the insulin signaling pathway in these tissues. Hypertension adversely affects several body functions, including increased vascular resistance and stiffness, causing peripheral vascular disease, structural heart disease, and cardiomyopathy, and leading to renal impairment. Dyslipidemia associated with metabolic syndrome can drive the atherosclerotic process, leading to symptomatic ischemic heart disease. The primary goal of the management is to identify and treat the risk factors and reduce the cardiovascular complications of metabolic syndrome. The recommended lifestyle modifications include physical activity, a healthy diet, avoiding tobacco use, good sleep hygiene, and decreased alcohol consumption. The American Heart Association and American College of Cardiology recommend 150 minutes of moderate intensity or 70 minutes of high intensity physical activity weekly. A diet rich in Vegetables, fruits, legumes, whole grains, nuts, and fish is recommended to reduce cardiovascular diseases. It is also recommended to avoid processed foods, refined carbohydrates, a diet rich in saturated fat, and reduce the amount of sodium. Social support and the management of psychosocial stressors are significant for the maintenance of a healthy lifestyle. Drug therapy is commonly recommended for the treatment of dyslipidemia, hypertension, and insulin resistance or diabetes. We've been talking about glucose levels and diabetes as chronic diseases, but let's discuss this more. Diabetes mellitus is a metabolic disease. There are different types of diabetes, but we are only going to cover two of the main subtypes in this module, type 1 and type 2 diabetes. We will cover gestational diabetes, which can occur during pregnancy, in the life cycle module. In the case of diabetes, insulin is either absent and or has impaired action, insulin resistance, and thus leads to hyperglycemia. Type 1 diabetes is characterized by the destruction of beta cells in the pancreas, typically secondary to an autoimmune process. The result is the absolute destruction of beta cells, and consequently, insulin is absent or extremely low. The onset of type 1 diabetes typically is in the childhood years. The peak onset occurs at ages 4 to 6 years old, and then again at 10 to 14. A majority will present with type 1 diabetes before 10. Common symptoms include weight loss and fatigue because the body cells are starved of glucose. Excess glucose from the blood is also excreted in the urine, increasing urination and thirst. Risk factors for type 1 diabetes include genetics and potentially infections in utero, perinatal, or early childhood. Type 2 diabetes involves an imbalance between insulin levels, and insulin sensitivity causes a functional deficit of insulin. The onset for type 2 diabetes is typically later in life, though due to increasing rates of adolescent obesity, type 2 diabetes has increased in younger populations. Type 2 diabetes involves a complex interplay between genetics and lifestyle. Insulin resistance is multifactorial, but commonly develops from obesity and aging. When insulin resistance is a component, the full extent of the disease results when the patient has inadequate production of insulin to compensate for their insulin resistance. With insulin resistance, initially the pancreas is producing enough insulin, but the body cells don't respond appropriately. It's as if you have the insulin key but can't find the keyhole to unlock the doors and let the glucose in. The result is the same: high blood glucose. The pancreas tries to compensate by making more insulin, but over time it becomes exhausted and eventually produces less insulin, leading to a diagnosis of type 2 diabetes. If you have high blood sugar, triglycerides, and LDL cholesterol, along with low HDL cholesterol, this can indicate insulin resistance. Risk factors for type 2 diabetes include obesity, family history of diabetes, sedentary lifestyle, prediabetes, and a history of gestational diabetes. Additionally, fatty liver disease is another risk factor. Individuals with type 1 and type 2 diabetes share several cardiometabolic complications, such as endothelial dysfunction, changes in glomerular filtration/kidney function, low-grade inflammation, oxidative stress, blood coagulation, mitochondrial dysfunction, cardiac dysfunction, anabolic resistance, metabolic inflexibility, and gut microbiota dysbiosis. The complications of type 2 diabetes result from long-term exposure to high blood glucose or hyperglycemia. Essentially, hyperglycemia causes damage to the heart, blood vessels, kidneys, eyes, and nerves, increasing the risk of heart disease and stroke, kidney failure, blindness, and nerve dysfunction. People with uncontrolled type 2 diabetes can also end up with foot infections and ulcers because of impaired nerve function and wound healing. If left untreated, this results in amputation. Lastly is diabetic ketoacidosis, or DKA. We are going to cover this on the next slide. DKA is a serious, potentially life-threatening complication of diabetes characterized by hyperglycemia, acidosis, and ketonemia. Although most often associated with type 1 diabetes, it can also occur in patients with type 2 diabetes. The development of DKA commonly results from new onset diabetes, underlying infections, or poor adherence to therapy. Additional stressors such as acute illness, trauma, or medication effects may also precipitate the condition. Commonly accepted criteria for DKA include blood glucose levels greater than 250, an arterial pH of less than 7.3, a serum bicarbonate level of less than 15, and the presence of ketonemia or ketonuria. In acute DKA, the ketone body ratio increases from a reference range of 1:1 to as high as 10:1. The severity of DKA stems from its rapid onset and potential to cause significant morbidity and mortality if unrecognized or untreated. Hypoglycemia represents the most common complication during the treatment of DKA. Acute consequences of hypoglycemia include seizures, cardiac arrhythmias, and other cardiovascular events. Severe hypokalemia can lead to muscle weakness, cardiac arrhythmias, and cardiac arrest. The primary management approach to DKA includes fluids, insulin therapy, electrolyte replacement, and supportive care. Immediate fluid administration is vital to correct hypovolemia, restore tissue perfusion, and clear ketones. Hydration subsequently improves glycemic control independent of insulin. Patients with DKA would be treated with insulin until the condition resolves. Those previously treated with insulin may be recommended to adjust their home dose if they have been well controlled. Electrolytes are also key. Patients with DKA are often found to initially have mild to moderate hyperkalemia despite a total body deficit of potassium. The initiation of insulin causes intracellular shift of potassium, lowering the potassium concentration and potentially resulting in severe hypokalemia. Insulin administration may be delayed initially to ensure potassium levels are corrected to prevent cardiac arrhythmias, arrest, and respiratory muscle weakness. Hypokalemia is commonly associated with hypomagnesemia. Repletion of both potassium and magnesium may be necessary, and improving potassium levels can be challenging until magnesium levels are replenished. Let's review testing for diabetes. Any testing for diabetes is typically done over 2 occasions for a formal diagnosis. There are 2 main criteria, the A1C and fasting glucose. The A1C test measures your average blood glucose for the past 2 to 3 months. If your A1C is less than 5.7%, then this is normal. Between 5.7% and 6.4% is prediabetes, and greater than or equal to 6.5% is diabetes. This is typically the test used for diagnosis. The A1C test can also be reported as an estimated average glucose. For example, an A1C of 6% indicates an estimated average glucose of 126 milligrams per deciliter. An A1C of 7% indicates an estimated average glucose of 154 milligrams per deciliter. When sugar enters your bloodstream, it attaches to hemoglobin, a protein in red blood cells. People with high blood sugar levels have more sugar attached to hemoglobin. A1C measures the percent of red blood cells that have sugar-coated hemoglobin. Other tests that may be done include fasting blood glucose. Less than 100 milligrams per deciliter is normal. 100 to 125 milligrams per deciliter indicates prediabetes, and greater than or equal to 126 milligrams per deciliter indicates diabetes. Prediabetes is a condition in which the blood sugar levels are higher than normal, but a formal diagnosis of diabetes is not given because levels are not high enough. Individuals with prediabetes have an increased risk of diabetes and cardiovascular disease and stroke. Individuals with prediabetes often may show no signs or symptoms of diabetes, but will have blood sugar levels higher than normal. Treating diabetes and managing glucose levels requires a balance of a combination of approaches, including lifestyle interventions and often medications. Outcomes are improved if an individual can manage their diet, exercise regularly, and monitor glucose. We will cover the dietary portion next. However, one thing to point out is that having diabetes does not mean you are on a special diet with special foods. It really is just a balanced diet with regular, consistent meals. The combination of exercise with dietary interventions have been extensively studied and found to result in additional positive cardiometabolic adaptations. Exercise is the most effective non-pharmacological tool to prevent and treat cardiometabolic diseases related to both types of diabetes. The combination of acute resistance and aerobic exercise can improve glycemic control, metabolism, oxidative stress, inflammation, and skeletal muscle anabolic adaptations. It is important to keep in mind that exercise can cause blood glucose levels to drop too low. Making sure to have adequate food intake before exercise and a plan in place for managing blood glucose levels is key. Low blood sugar is typically less than 70 milligrams per deciliter. The 15-15 rule is an approach. This involves having 15 grams of fast digesting carbohydrates like juice or glucose tabs, followed by a waiting period of 15 minutes before testing again. If above 70 milligrams per deciliter and the next meal is an hour away, have a snack. If still too low, you would repeat 15 grams of carbs and wait 15 minutes. Regular testing to increase awareness of blood glucose levels can also be helpful. Most physicians recommend 6 months or yearly labs to check A1C and fasting blood glucose levels. Ideally, glucose levels should be maintained at 90 to 130 milligrams per deciliter and A1C less than 7%. While glucose control is critical, excessively aggressive management may lead to hypoglycemia, which can have adverse or fatal outcomes. In addition, daily testing is typical if not using a continuous glucose monitor. Some doctors will recommend AM fasting tests and others recommend testing more frequently, 4 times a day. Typically, this includes when first waking, before a meal, 2 hours after a meal, and at bedtime. Targets for glucose include 80 to 130 milligrams per deciliter before a meal, and for 2 hours after the start of a meal, less than 180 milligrams per deciliter. Medication may be needed to treat diabetes. For those with type 1 diabetes, insulin is necessary as the body does not produce any. For advanced type 2 diabetes, insulin may also be necessary, but in less severe cases, oral meds may be prescribed. Lastly, the care team is important. This can include an endocrinologist who specializes in diagnosing and treating health conditions relating to the endocrine system. This includes not just diabetes, but also thyroid diseases, infertility, and metabolic disorders. A dietitian is a critical component for diabetes management. Dietitians utilize medical nutrition therapy, which is effective and associated with A1C absolute decreases of 1 to 1.9% for people with type 1 diabetes and 0.3 to 2% for people with type 2 diabetes. Referrals to RDNs are particularly warranted when a person with diabetes is dealing with additional health conditions such as hypertension, dyslipidemia, heart failure, gastrointestinal disorders, chronic kidney disease, pregnancy-related nutrition concerns, pediatric growth issues, or obesity. There are a variety of evidence-based meal patterns that can be utilized for diabetes management. The Mediterranean diet can reduce A1C, triglycerides, and risk of cardiovascular events. This diet includes plant-based foods, fish and other seafood, olive oil as a main fat source, dairy at low to moderate amounts, less than 4 eggs per week, low amounts of red meat, low to moderate red wine, and rare concentrated sugars. Vegetarian and vegan diets can reduce A1C, LDL, and non-HDL cholesterol values. Additionally, these patterns can assist with weight loss. Plant-based foods are emphasized, with animal products excluded for a vegan diet. A vegetarian diet would exclude meats, seafood, or poultry, but include eggs and or dairy products. We will talk more about both of these diets when we cover proteins, as there are many variations. A low-fat diet, which is defined as less than 30% of calories from fat and less than 10% of calories from saturated fats, have been shown to assist with diabetes and weight loss. This diet would include fruits, vegetables, lean proteins, including beans, low-fat dairy, and carbohydrates from whole grains and starchy vegetables. A very low-fat diet, which is defined as less than 10% of calories from fat and 70 to 77% of calories from carbohydrates, has been shown to assist with weight loss and reducing blood pressure. This would include fiber-rich vegetables, beans, fruits, whole grains, non-fat dairy, fish, and egg whites. A low-carbohydrate diet, which is defined as less than 26 to 45% of calories from carbohydrates, has been shown to assist with weight loss, reducing A1C, lowering blood pressure, increasing HDL, and lowering triglycerides. This would include non-starchy vegetables, healthy fats, protein from meat, fish, poultry, shellfish, eggs, cheese, nuts, and seeds, and quality carbohydrates, but in limited amount. A very low carbohydrate diet, which is defined as less than 26% of calories from carbohydrates, has been shown to assist with weight loss, reducing A1C, lowering blood pressure, increasing HDL, and lowering triglycerides. The meal pattern is similar to a low carbohydrate diet, but limits carbohydrates more. Typically, 20 to 50 grams of non-fiber carbohydrates per day are allowed. Lastly is the DASH diet, or dietary approaches to stop hypertension. This has been shown to reduce the risk of diabetes, assist with weight loss, and reduce blood pressure. This includes fruits, vegetables, low-fat dairy, whole grains, poultry, fish, nuts, reduced saturated fat, red meat, sweets, and sugary beverages. It may also be lower in sodium. The key to choosing a dietary pattern is working with the healthcare team to determine what is best for not just diabetes, but managing other complications. In the Standards of Care in Diabetes 2026, it is noted that there's no ideal percentage of calories from carbohydrate, protein, or fat for people with diabetes. Therefore, macronutrient distributions should be based on an individualized assessment of current eating patterns, preferences, and metabolic goals. Additionally, there is a call for more evidence around benefits of specific eating patterns. As such, it is recommended that common core components of different dietary patterns are emphasized. Let's look at the common core components to emphasize, along with a bit more on the standards of care. The Standards of Care in Diabetes, Standards of Care, includes all current clinical practice recommendations of the American Diabetes Association, ADA, and is intended to provide clinicians, researchers, policymakers, and other individuals with the components of diabetes care, general treatment goals, and tools to evaluate the quality of care. The recommendations included in the Standards of Care are based on an extensive review of the clinical diabetes literature, supplemented with input from ADA staff and the medical community at large. The Standards of Care in Diabetes is updated annually or more frequently online if new evidence or regulatory changes merit immediate incorporation, and is published in Diabetes Care. This slide has a citation and link for the Standards of Care. We are going to focus primarily on the dietary portion of this, specifically the nutrition recommendations and those core components among different dietary patterns. So the core components to emphasize include non-starchy vegetables, whole fruits, legumes, whole grains, nuts, seeds, and low-fat dairy products or non-dairy replacements. It is recommended to minimize consumption of red meat, sugar-sweetened beverages, sweets, refined grains, and processed and ultra-processed foods. Additional considerations include limit sodium consumption to less than 2,300 milligrams a day as clinically appropriate, primarily by reducing processed foods. Aim for water over other beverages. Utilize non-nutritive sweeteners in place of sugar-sweetened ones if consumed in moderation, and then to reduce caloric and carb intake. Emphasize minimally processed, nutrient-dense, high-fiber sources of carbohydrate. Incorporate more plant-based protein sources, nuts, seeds, and legumes as part of an overall diverse eating pattern to reduce cardiovascular disease risk. Aim for a consistent pattern of carbohydrates and monitor carbohydrates. Studies examining the optimal amount of carbohydrate intake for people with diabetes are inconclusive. Regardless of carbohydrate quantity in the meal plan, the focus should be on high-quality, minimally processed, nutrient-dense, high-fiber carbohydrate sources. Limit or avoid alcohol. The World Health Organization declared that there is no safe amount of alcohol intake. Associated risks of alcohol consumption include hypoglycemia and or delayed hypoglycemia, weight gain, and hyperglycemia for those consuming excessive amounts. Limit saturated fats to help reduce cardiovascular disease risk. There are a few different options we discussed already for dietary approaches. The ADA's Diabetes Plate is a framework that can work with all meal patterns, but is specifically focused on the lower carbohydrate meal plan. The idea is that it can be adapted though. With the Diabetes Plate, half the plate would be non-starchy vegetables, a quarter carbohydrates, and a quarter protein. The top features water or 0-calorie drinks. Non-starchy vegetables are lower in carbohydrates, high in vitamins and minerals and fiber. With proteins, the goal is to emphasize those that are low in saturated fat and cholesterol. Both animal proteins like fish or chicken can be included along with soy foods like tofu and tempeh. Carbohydrates are still included in a dietary plan for those with diabetes. With carbohydrates, the idea is to include those that are higher in fiber, like whole grains, starchy vegetables, beans, legumes, and whole fruits. If you're wondering, fruit can still be incorporated for those with diabetes. The goal is to aim for whole fruits over juices, which contain vitamins, minerals, and fiber. When meal planning with diabetes, healthy fats are also emphasized along with water or any unsweetened beverage.